A very good evening to everyone. A warm welcome on behalf of SPEED organizing team to the all respected faculty members and all delegates. Special thanks to the SPEED family scientific committee of this year for giving me opportunity to present SPEED oration of this year. The topic that I'm going to speak is, Dr. Tandon sir just spoke about hyperthyroidism. I will be speaking about hypothyroidism Indian perspective. So before I start my presentation, it's my duty to present my sincere gratitude and thanks to a few persons who have immensely helped me in my career in endocrinology. So first and foremost, thanks goes to my teachers, AIMS endocrinology family. We can never forget late Professor A.C. Amni. She is into our heart for rest of the life. Two teachers who have really helped me a lot in my career and still, on a day-to-day basis, they are helping me. Professor Nikhil Tandon, whom we just listened, and Professor Rajesh Khadgawat, who has been my thesis guide as well. SPEED family, definitely they deserves a lot of thanks from my side, starting from Dr. Sanjay Kalra, who helped me a lot in my early career. Then everyone from Sameer, Saptrisi, Deep, Vineet, Atul, Rajiv, everyone, in SPEED, who have been always sort of motivating in terms of collaborating, in terms of writing, in terms of publications. Then definitely family deserves a special thanks because whatever time we take out in the busy clinical practice in writing and publications, it is primarily at the expense of personal family time. So a special thanks to my parents, Mr. Sri Hariom Khandelwal and Srimati Asa Devi, and you can see three beautiful girls, Aarti, my wife, she is a rheumatologist, and two lovely daughters, Nandini and Nishani. Definitely clinic staff, they also deserves a special thanks. They have been supporting on day-to-day basis for all the clinic activities, all research-related activities. And last and not the least, Maharaja Agreshan Hospital, Punjabi Bagh, where I worked for almost 9 years. And two persons I would like to sincerely thanks, Dr. Vivek Agarwal, who has been endocrine surgeon there, and Dr. Suresh Mittal, who is a senior consultant physician there. And they have really supported me in my tenure in last 9 years. Now I have resigned from the hospital for last 1 year. About this topic, hypothyroidism, definitely, interest is definitely inclined once we are into the endocrinology. So after diabetes, the other common problems that we see in practice is thyroid disorders. Among thyroid disorders, definitely hypothyroidism is the most common endocrine disorder after diabetes that we see in day-to-day practice. But my interest into this topic actually, in terms of research, in terms of writing, started way back in 2011. And it may be a very small thing for Professor Tandon because as usually got sort of, invitation to write a review for very reputed journal that is drugs. It was, I think, in 2011 and he asked me, why don't you write this review? So for me, it was a very difficult task, while doing my DM training, but I accepted that challenge and it took almost 7 to 8 months that point of time. But I think in 30 minutes, you must have realized when you work with Professor Tandon, you not only learn thyroid, endocrinology, you learn so many things, whether it is writing, English, grammar, ideas, everything, within that span of time. I remember I used to mail him after 3 weeks of hard work, overnight writing, and my mails used to get reply within 30 minutes and complete dissection of whatever I have done in last 2 or 3 weeks. So eventually this article was published on 1st of January 2012 in this journal Drugs, very exhaustive review, almost 20 pages review. And this is very well appreciated article, 187 citations till date that I consider as very good number. So about this topic, this is my flow of discussion that I will be presenting. Introduction to the topic, clinical features, management, physicians and patients perspective, whatever Indian data that we have, challenges of managing hypothyroidism in India, and then finally take home messages. So hypothyroidism is nothing. It is when your thyroid gland is not able to make adequate amount of thyroid hormone to meet the requirement of peripheral tissues. So very simply, deficient production of thyroid gland by the thyroid gland. It can be primary hypothyroidism when it is abnormality in the thyroid gland itself, or it can be secondary or central hypothyroidism when it is as a result of pituitary or hypothalamic disease. The most cases that we see in day-to-day clinical practice, it is primary hypothyroidism, more than 99% cases of hypothyroidism. It is characterized by failure of the thyroid gland itself. What is important, there is an inverse relationship between T4 and TSH. Decrease in T4 will result in increase in TSH, as Sir was talking about, because of feedback phenomena. What is more important, it is inverse log linear relationship, means a small decrease in T4 will cause significantly higher increase in TSH concentration. That's why you can divide primary hypothyroidism into overt category, where you have elevated TSH in presence of low free T4 concentration, and subclinical hypothyroidism by definition is elevated TSH in presence of normal free T4 and normal free T3 concentration. What is important, it is actually a metabolic hormone. It affects almost every organ in the body, whether it is eyes, lungs, kidney, skin, whatever. So symptoms and signs, they may pertain to any organ system in the body. If you see the list of symptoms and signs, you see a very long list: exhaustion, somnolence, slow cognition, emotional lability, cold intolerance. So what is important, just to sensitize you, this is a young girl who came to my OPD with very vague symptoms of generalized weakness, decrease in school performance, always tired, and these symptoms, they had been there for 4 to 5 months. When thyroid testing was done, it was more than 250 and undetectable free T4. Why I'm highlighting it here, of course, all of you must have seen these kind of cases in practice. Symptoms and signs are quite non-specific, and it's not really uncommon to miss hypothyroidism, even to the tune of severe hypothyroidism. Symptoms are related to duration of hypothyroidism, severity of hypothyroidism, and rapidity with which hypothyroidism develops. As you know, Dr. Tandon sir was talking about, if somebody is a hyperthyroid patient, you give them radioiodine ablation and suddenly make them hypothyroid, they are much likely to have, profound symptoms like cramps in large muscles and other symptoms. What is really important is new symptoms, multiple symptoms, and persistent symptoms. So your constipation may not be a sensitive symptom for hypothyroidism, but new onset constipation in a person with regular bowel habits for many years may be an indicator for hypothyroidism in that particular person. This is Indian Thyroid Registry we published, I think 5-6 years back. So this is probably one of the largest database of newly diagnosed hypothyroid patients from India. I was one of the investigators for this study. 1500 newly diagnosed treatment-naive adult hypothyroid patients, 33 centers in India, mean age 41 years, female to male ratio 7:3. So you can see disease is more common in females, being autoimmune disease. So nothing unusual, symptoms and signs, they were really concordant with whatever literature is there from other countries as well. You see fatigue was there in almost 60%, then other symptoms like weight gain. Signs, you can see hair fall, swelling of limbs, and dry coarse skin. What is really important from gynecology perspective, any kind of menstrual abnormality, whether it was irregular cycle, menorrhagia, or intermenstrual bleeding, it was one of the sensitive symptoms in premenopausal women with hypothyroidism. This is one editorial, and you can see, all my SPEED colleagues, whether Samir or Dr. Kalra, they will be, co-author in all these articles that I will be showing. So on one hand, I was saying symptoms and signs, they are insensitive, they are non-specific. On the contrary, presence of certain symptoms and signs must always alert you to check for thyroid function test. Simple scenarios: any child coming with short stature, any child coming with pubertal disorders, anybody coming with goiter, menstrual irregularity in females, ataxia, galactorrhea. So hypothyroidism may not be a common cause for ataxia, but it is important treatable cause of ataxia. Another important thing that we realize in clinical practice, that we very oftenly see patients of severe hypothyroidism. However, when we see the literature, published literature on severe hypothyroidism is very limited. So this is one of the study we published in Indian Journal of Endocrinology and Metabolism in 2019, thyroid symptomatology across the spectrum of hypothyroidism and impact of levothyroxine supplementation in patients with severe primary hypothyroidism. So the severe hypothyroidism was defined as TSS at least 40 in this particular study, and that's based on previous literature that, after this cutoff of TSS of 40, there can be pituitary hyperplasia. So what you see here, symptoms, they are more likely to be profound in this particular population. You see fatigue here in 90% as compared to it was 60% in Indian Thyroid Registry. Similarly, other symptoms and signs, they are more likely to be common. Important thing that I would like to highlight from here, if you see mean TSH in this particular study in patients who have severe primary hypothyroidism was 140, more than 100, because we included patients only with TSH at least 40. After 12 weeks, mean TSH 3.81, almost euthyroid, change in body weight. only 2.85 kg. Because a lot of people think hypothyroidism can cause profound weight gain. That's not true. Weight gain even in severe primary hypothyroidism is less than 5 kilogram, and that's primarily because of fluid retention and of course some increase in lipogenesis. So one of the important messages of the day, hypothyroidism does not cause morbid obesity. So just to again, because you see this young girl, because severe hypothyroidism was missed for many, many years in this girl. 19-year-old girl, born age is only 11 years. So at least 8 years of hypothyroidism was missed. On the contrary, you see on her face, it is written that she is hypothyroid. This girl came from a remote village in UP. You see chest X-ray showing cardiomegaly because of pericardial effusion. Somebody did TSH in dilution that was more than 1,000. And within 3 months, you can see remarkable change in face. So what is important, these kind of patients, I think important message we should not be missing in day-to-day clinical practice, because these are the patients, they are not going to come to us. They are going to their general physicians for vague symptoms like puffiness on the face, hair fall, dull child, inactive child. This is one review article we published last year only, thyroid dysfunction and dysmetabolic syndrome. So there is a definite need for more thyroid vigilance in patients with various metabolic problems, various dysmetabolic syndromes that may include diabetes, that may include obesity and overweight, that may include dyslipidemia, that may include non-alcoholic fatty liver disease, that may include polycystic ovarian disease. So what is important if you see from diabetes perspective, of course, when it comes to type 1 diabetes, absolutely no doubt, because both type 1 diabetes and thyroid disorders, they are autoimmune disease. Annual screening for thyroid functions is recommended in persons with type 1 diabetes. Also, there's a clear data, a lot of studies also from India, that thyroid disorders are more common in persons with type 2 diabetes. Of course, there are no clear recommendations, no clear guidelines, but at least higher thyroid vigilance is required in these persons, at least baseline TSH estimation, and in clinical practice based on your patient to patient, you may like to recheck for thyroid in 3 to 5 years in these persons. This is one of the study we published in Thyroid Research and Practice, Prevalence of Hypothyroidism and Thyroid Autoimmunity in girls with Pcod. So we studied almost 70 women with polycystic ovarian syndrome. We found higher mean serum TSH level in PCOS as compared to age-matched controls. Also numerically higher subclinical hypothyroidism and TPO positivity, but that was not statistically significant. Important message, any dysmetabolic syndrome, you have to be more vigilant for thyroid and you have to screen for thyroid. Coming to the treatment part, I think it is very simple. Any patient of overt hypothyroidism, when TSH is elevated, T4 is low, it requires treatment. Treatment in majority of patient is lifelong, so it is always better to check the samples with a repeat sample. When TSH is more than subclinical hypothyroidism and TSH more than 10, again, I think absolutely no doubt, again, most of the guidelines, most of the recommendations, they are clearly in favor of the treatment. The important thing, you have to establish the diagnosis with at least 2 TSH samples, at least 2 to 12 weeks apart. In this subcategory of patients, it is associated with higher conversion to overt hypothyroidism, and also TSH more than 10 is clearly linked with dyslipidemia. So these patients, they require treatment. Only controversy is patients with TSH less than 10 and subclinical hypothyroidism, and this is the algorithm that we had postulated, we had given in our review article. If it is in context of pregnancy, planning pregnancy or infertility, yes, they require treatment. Somebody you are thinking they might have symptoms related to hypothyroidism, you can give a trial of levothyroxine. If the symptoms improve, you continue treatment. Symptoms do not improve, you discontinue treatment. Other indications, they can be if somebody is having goiter and significantly positive TPO antibody titer. Other patients, you may just like to follow up with annual or 6 monthly TSH in your practice. Treatment is very simple. You have to start levothyroxine. In most adult patients, you can, who are having overt hypothyroidism, you can start with the full replacement dose, that is 1.6 microgram per kg of ideal body weight. But treatment should not be started with full replacement dose in elderly patients, patients with coronary artery disease, and patients with long-standing severe hypothyroidism who may suddenly not tolerate higher doses of levothyroxine. Of course, when it comes to subclinical hypothyroidism, your doses of thyroxine, they are going to be small, depending on degree of TSH elevation, degree of age, and depending on body weight. Another important thing, elderly population. An important message is subclinical hypothyroidism, especially less than 10, does not require treatment in elderly population. In fact, there's a data that age more than 85 years, subclinical hypothyroidism, TSH up to 10 is actually associated with longevity. And if you treat these individuals with levothyroxine, you probably harm them. So you need to be more conservative for treatment of subclinical hypothyroidism in elderly. When it comes to adjustment of T4 dose, I think again, as Dr. Tandon was showing us, we have to monitor routine thyroid function test. In most patients, you like to have TSH in the lower half of the normal range. But generally, when it is normal patients, they are doing well, you just continue the same doses. When the TSH is high or low, you can make changes in the doses from 12.5 to 25 microgram. In central hypothyroidism, you have to follow patients with free T4 and not TSH. Another important thing, as we talk about patient-centered management of diabetes, as we talk about individualizing HbA1c targets, similarly, we can individualize TSH targets as well. And this is one of the editorial that we published. Like some patients who are younger, who are having planned for pregnancy, who have dyslipidemia, who have metabolic problems, patients of CA thyroid, in those patients who would like to have TSH little sort of, in the lower half of the normal range. On the contrary, if they are elderly patients, patients with atrial fibrillation, patients with osteoporosis, somebody starts developing palpitations as soon as you start levothyroxine, you may like to have higher range of TSH values. This is one of the studies we published as part of during SPEED meeting as SPEED collaboration workup 2016 clinical practice pattern in the management of primary hypothyroidism among doctors from different clinical specialties in New Delhi. So we did the questionnaire-based survey of practicing physicians who attended our SPEED meeting. Important thing that I would like to highlight from here, in this particular study, more than 50% of physicians, they wanted thyroid ultrasonography in hypothyroidism. However, there is no role of ultrasonography in garden variety of hypothyroidism, except when patient has nodularity on thyroid examination. Similarly, there were other issues. I'm not here to criticize. Important thing, more awareness, more educational programs, and that's why we are here today as well. This is one of the review article, Diagnosis and Management of Hypothyroidism. Again, what was the important message? More thyroid awareness among general practitioners, early pickup of hypothyroidism at the community level, optimal workup, early treatment, and optimization of treatment. Coming to the patient's perspective, this is one of the DNB thesis, as we did this research work as part of the DNB thesis, knowledge, awareness, practices, and adherence to treatment in patients with primary hypothyroidism in Delhi. We studied 250 patients, mean is 43 years, median duration of hypothyroidism 8 years. So they were already taking levothyroxine for longer period of time, but they came to us for the first time either in the hospital or in the clinic. Most patients, they were from well-to-do families because they were coming to the private clinics. They were well educated, more than 50%, they were graduates or postgraduates. In spite of that, knowledge and awareness related to the thyroid was actually poor. Most of them, they did not knew the correct meaning of thyroid, hypothyroidism. They did not knew why we are replacing levothyroxine. More than 40%, they had false dietary beliefs. A lot of people do think that, once TSH is normal, they can stop their levothyroxine. Similarly, myths related to weight gain, myths related to whether this treatment can be continued or whether it is safe during pregnancy. This is the almost similar kind of study, only thing it was done at multiple centers. I was also part of that. So in this was a cross-sectional survey, almost of knowledge, attitude, and practices with hypothyroidism in India. In this study, 16 centers, 500 patients, again done in private clinics. Patients were well educated, but knowledge and awareness related to thyroid disorders or hypothyroidism was really poor. Almost replicative findings, similar kind of dietary beliefs, similar kind of myths related to thyroxine. We often, another important thing that I've realized in clinical practice, we prescribe levothyroxine, but we fail to deliver simple instructions related to levothyroxine. Many patients, as part of survey also we identified, they are taking it post-meal. They are not able to make adequate gap after levothyroxine between their morning tea or food. So simple instruction sheet can help. And, and I have got printed pamphlets of this medication counseling for levothyroxine, which is being given to every patient and which is explained to every patient, and it really works. Otherwise, you might think your patient is doing absolutely okay. Their TSH keeps on fluctuating. When you inquire them, sometimes they are taking their morning tea 10 minutes after their levothyroxine tablets. They may be well-educated patients. They may be already having thyroid disorders for more than 10 years. So medication counseling is another important thing. Another important thing is thyroid stress. This article is published by Dr. Sanjay Kalra. So I have very often observed in clinical practice, especially in young females, sometimes young females who have just conceived TSH of 8 and they are in so much of panicky, what will happen to their pregnancy, what will be the outcome. So I have seen unmarried females coming to us with borderline hypothyroidism and they are very much worried about their reproductive life later on. So this is, as we talk about diabetes distress, we talk about insulin distress, there may be something that is called as thyroid stress as well, and it is nothing, it is simply lack of education, lack of awareness. If we educate them, if we tell them all the true facts, that can easily be mitigated. This is one of the review article we published in Journal of Indian Medical Association, just highlighting all these points, patients' knowledge and perception about hypothyroidism. So important message from here, it highlights the need for an aggressive awareness programs in India. Health literacy, counseling and education programs needs to be developed in both clinical and community setting, and probably time to have thyroid educators on board. So as we talk about diabetes educators, we can also talk about thyroid educators. So they may not be separate personnel. Your routine clinical staff, they can be trained for that. Simple instruction sheet, simple, sort of messages, it can do our work. So just to summarize, it is a common disease, but presentations may be uncommon. Most symptoms are non-specific. Many times disease is asymptomatic, and it's not uncommon to miss hypothyroidism, even severe hypothyroidism. Not uncommon to see severe hypothyroidism presenting with uncommon manifestations like precocious puberty, like coming with galactorrhea, coming with ataxia. So thyroid vigilance is required in clinical practice. Subclinical hypothyroidism all need not be treated. Patient-centered treatment is proposed like for diabetes. You can individualize the TSH targets depending your patients to patients. Medication counseling and patient education is important. Lot of awareness is still required at physicians and patients level. Need for an aggressive awareness programs in India, and thyroid stress is commonly seen in clinical practice in India. Thank you very much.
Thank you, Dr. Deepak, as usual, crisp and showing his great research in the field of thyroid diseases. I think it was quite mesmerizing hearing him. So I think it's an honor to have him on the stage. Thank you, Dr. Deepak Khandelwal. I request Professor Nikhil Tandon sir to honor Dr. Deepak Khandelwal, to felicitate him, since this is a oration talk. We are lucky to have our teacher. He doesn't need any introduction. Dr. Nikhil Tandon sir, please. Oh, did